Good. All right. Sounds good. So the purpose of the presentation today is to review the physiologic impact of the balloon pump on LV function and to review contemporary clinical studies related to balloon pump use. Now, additionally, tools to determine if the patient is responding to balloon pump therapy will be discussed to aid in escalation of mechanical support if required by patient condition. And in disclosure, I am an employee of Teleflex, and a portion of the WAVE research was funded by Aero International. And Teleflex, like Ty said, is a manufacturer of balloon pump catheters and pump systems. Now, acute heart failure or cardiogenic shock occurred in approximately 10% of AMI patients, and the mortality continues to be greater than 40%, with little progress having been made in the last decade to reduce mortality. The immediate goals of therapy for these patients are obviously to restore and maintain systemic perfusion and to avoid the development of secondary multi-system organ failure, which obviously increase the risk of death. Now, as we know, first-line treatment involves fluid management, vasoactive agents, but vasoactive agents, we know, increase the risk of mortality and decouples the LV function from the arterial system, which can result in damage or failure of the left ventricle. Now, if the first two lines of treatment do not adequately support the cardiac output and hemodynamics, MCS, mechanical circulatory support devices, such as the balloon pump, may be implemented to provide mechanical support of the hemodynamics until the primary treatment can be accomplished. Early use of these devices has been shown to improve outcomes. Now, heart failure due to left ventricular dysfunction is categorized according to ejection fractions. This is more the modern look at classifications. And today there are three generally accepted types of heart failure. And HFrEF, as it's nicknamed, heart failure with reduced ejection fraction, are those patients who have EFs less than 40%. This is also known as systolic heart failure and includes cardiogenic shock. HFpEF, so heart failure with preserved ejection fractions, are patients who have EFs greater than 50%. This is also known as diastolic heart failure. And an example of these types of patients would be an aortic stenosis type patient. And then HFmrEF, or moderately reduced ejection fractions, is a very tight little window of that 41 to 49% EF, and these may include our pre-shock syndromes. Now, mechanical circulatory support systems are generally used in the HFrEF and the HFmrEF patients when LV dysfunction cannot be managed by drug therapy alone. And on this slide, this is a nice one because it shows the treatment options for both inotropic support and escalating mechanical support for heart failure. And as mechanical and inotropic support increases, in-hospital mortality is also increased. This slide here shows the treatment options for mechanical circulatory support based on the level of pharmacological support the patient requires. Now, escalating inotrope doses or addition of a secondary or third inotrope may indicate the need for more advanced mechanical circulatory support that can create more cardiac output. So you can just see as the dose increases, as the number of inotropes increase, we may need to add a higher level of mechanical circulatory support. It's just that escalation that we all talk about. Now here we have a quick summarization of the current US and ESC levels of recommendations for balloon pump use in various clinical conditions. And these are all current guidelines. And you can see that in general, the support level is moderate to strong for balloon pump use. Now, the balloon pump we know is the most commonly used form of MCS available today. And balloon pump therapy has been well established for over 50 years, as its physiologic benefits are well matched to the patients with comprised LV functions. And the balloon pump exerts its effect, we know, by volume displacement, opposite or counter to the cardiac cycle, hence the term counterpulsation. Now, simply said, counterpulsation therapy increases perfusion to our coronary arteries and decreases the afterload of the heart. And rapid deflation of the balloon reduces the length of the isovolumetric contraction phase in MVO2. Since approximately 90% of our MVO2 is consumed during the IVC phase, reducing the length of the phase directly reduces MVO2. And the combination of an increased O2 supply and decreased O2 demand allows the LV to rest and possibly recover. And as afterload is reduced, LV hemodynamics can improve and oxygen supply and demand can be better balanced. This is especially important in patients with comprised LV function. Now, each type of mechanical device obviously has its own profile with respect to unloading, but also offer different levels of support. And if the patient fails initial therapy, early and timely escalation to the next appropriate device or drug therapy may improve the patient outcomes. Now, when we just look at kind of what a balloon pump is going to do with that ventricle, with that afterload, this PV loop we got from our conductance catheter in our wave studies shows the acute impact of a properly timed full volume and full assist balloon on the LV. So you can see that downward shift to the left. The impact of the LV unloading is seen within the first 3 to 4 beats and is due to the lengthening of the systolic ejection phase, which increases stroke volume. This reduces left ventricular end stroke volume and then left ventricular end systolic pressure. It is the change in volume that precedes the change in pressure. And this effect has been seen in all patients monitored using this technique during our studies. And the magnitude of the change varies based on the LV hemodynamics, but the direction and the speed of the change are consistent across numerous patients. So we still see that change regardless of other variables with each patient. Now, typically in the OR, we're used to having TEE to determine function and any associated dyskinesis or akinesis on the left ventricle. And as with the PV loop study, we used a conductance catheter to look at the impact that dyskinesis or akinesis may have on flow. So this is really looking at patients in heart failure, we all know have a higher risk of dysynchrony or discoordinated mechanical contraction, especially in the apical segments, as these are perfused by distal segments of the coronary arteries. And dysynchrony reduces the efficiency of LV ejection and reduced stroke volume and cardiac output. Now, this here is an example of a patient with dysynchrony in S1 and S2, and the apex and adjacent area of the heart. So you can see on the graph at S1 and S2 how disorganized the first few columns are of that flow. But at that black arrow at the bottom, that's where we instituted balloon therapy. It's where we turn the pump on. So dysynchrony is going to be reduced within 8 seconds of the balloon pump start. And this is due to the afterload reduction created by the balloon pump and a principle explained by Broussard. This is an important acute mechanism of the balloon pump, which improves ejection fraction, stroke volume, and obviously cardiac output. So again, this is an important thing to understand because what we care about is knowing the LV is ejecting the appropriate amount of stroke volume. And echo may show us what is causing the problem, but by looking at a segmental view, such as here, we can precisely measure the volume and what the effect of this is on stroke volume and cardiac output. So you can see towards the right of that graph in S1 and S2 that you do have a more uniform shape, so you do have more fluid flow from the ventricle, so it's more uniform. Now, almost every recent RCT randomized clinical trial done in cardiology over the last 5 to 10 years has not shown a benefit for the balloon pump, at least in short-term results. And these trials have had high levels of crossover, indicating that the clinician believed the balloon pump would provide some specific support to the patient. Most of these studies looked at short-term results, but it is well known that clearly the early mortality in cardiogenic shock is high. This leads to a number of patients dying before treatment can be initiated, which may not reflect the benefits of balloon pump in all settings or uses. As balloon pump therapy has been around for 50 years, it leads us to the question, have we been wrong about the benefits of the balloon pump for all these years, or has the focus on mortality and adverse events alone been incorrect in the face of the adjunctive nature of balloon pump therapy? Most of the evidence for balloon pumps have come from non-randomized trials, which do not directly compare the results of a group of patients treated with balloon pump to a similar group not treated with balloon pumps. This means the strength of the evidence is less, but interestingly, all of the recent trials have concluded that the balloon pump is safe, so the risk of using a balloon pump is minimal. Now we'll start to go through some of these trials that we're all probably familiar with. And these 3 pivotal trials for the balloon pump in the presence of cardiogenic shock have been performed. In Shock 1, it was published in 2000, can't believe it was 20 years ago, and included almost 1,200 patients. The trial was randomized multi-center trial, which compared several revascularization methods and the use of balloon pump on mortality, so the effect. The study concluded that early revascularization is key to improved outcomes. That's kind of an obvious statement. But while the balloon pump slightly reduced the door-to-balloon times, they were still under 90 minutes. So we still fell within that normal parameter. Balloon pumps did not impact mortality in PCI patients, but was associated with significant reductions in mortality in AMI patients treated with thrombolytics and for AMI patients who experienced mechanical complications, VSD, MR. Now, in looking at SHOCK-2 trial was published in 2012 and included 600 patients. The multi-center study randomized PCI patients with cardiogenic shock to balloon pump or no non-balloon pump groups and compared the outcomes. The balloon pump did not reduce short-term 30-day or longer-term 12-month mortality, but it did show that complications were similar in both groups and concluded that the balloon pump was safe. Now, the randomized RCT by SafeParth in 2008 compared 26 patients with Impella 2.5 versus balloon pump in cardiogenic shock. And the study found only an improvement in cardiac output in the first 30 minutes for Impella over balloon pump, and diastolic pressure was higher with Impella group. But after that, all other variables were similar. Complications were higher in the Impella group. Hemolysis was significantly higher, and there was one case of limb ischemia. So going back to SHOCK-2, it doesn't really tell the whole story. And the view of the experts who have reviewed the trial concluded that there's really four main issues to make it difficult to generalize the findings to all patients here. Number one, the sample size was based on a predicted 30-day mortality of 56%. And this has an 80% power of detecting a 12% reduction in mortality due to balloon pump use. But to be able to detect the specified treatment effect, the study would need over 900 patients. And again, there's only 600, so grossly underpowered. Crossover can dilute the difference between the treated and non-treated groups, making it harder to detect a treatment benefit. And patients who crossed over to the balloon pump group had significantly improved outcomes. Now, insertion pre-PCI has been shown to be most effective, but in SHOCK-2, over 86% of the patients had balloon insertion after PCI. Planned follow-up, when we talk about the follow-up look, currently follow-up is planned at the 6 and 12-month marks, which may not be long enough to detect a treatment benefit. Now, we'll go through BCIS-1 here shortly, and it demonstrated a mortality benefit at 51 months. That was not visible earlier in the study, and the authors recommend extending the follow-up period to see if a treatment benefit emerges over time. And a recent meta-analysis by Chen in 2013 demonstrated a long-term benefit greater than 6 months with balloon pump, despite no improvement at the 30-day benefit. Here we can see that there is a conclusion that early use of balloon pump for patients undergoing high-risk PCI due to cardiogenic shock improves in hospital outcomes. Chemical markers of ischemia and infarction were reduced in balloon pump patients and support other studies which concluded that preservation of myocardial function is key to improve survival and long-term outcomes. The study also supported early use of balloon pumps, specifically balloon pump use prior to PCI. And early use of balloon pump prior to PCI has been associated with reduction in MACE during or after PCI. Here, two RCTs, BCIS-1 and CRISP-AMI, were done to assess the impact of balloon pumps on AMI size and support for PCI. These had similar findings at the end of the initial trial, that is, the balloon pump did not improve outcomes. Now, BCIS-1 followed patients for 51 months and found a 34% mortality decrease in the balloon pump group. And after conclusion was that the balloon pump should be on standby for high-risk PCI patients and is beneficial in stabilizing patients with hemodynamic compromise. Now, CRISP-AMI did not demonstrate a reduction in the size of an MI in the balloon pump group as compared to the control group, but all-cause mortality was lower at 6 months in the balloon group. However, the groups were too small here for meaningful comparison. But a key finding of this study was that the insertion of the balloon pump did not increase door-to-balloon times. SHOCK-1 indicated that early revascularization was the most important factor in outcomes for patients with ACS. And as a result, many clinicians moved away from early balloon use in favor of faster door-to-balloon times. But CRISP-AMI showed that the balloon could be used without increasing the time to revascularization and was an acceptable bailout device, which should be available in all centers that perform PCI. Here's just a quick graph that demonstrated BCIS-1 demonstrated a trend toward reduced mortality at 6 months when the balloon pump was used and a significant reduction in procedural complications when the balloon pump was used. However, in long-term follow-up at 51 months, patients who received balloon pump therapy had significantly greater or better LV function than those that did not. This may indicate that early preservation of myocardial function may be more important for long-term LV function. And this conclusion has been supported in other studies, even not using the balloon pump. Now, while the primary endpoint of the study was mortality, the authors concluded that rescue balloon pumps should be an option in all interventional settings. Baker here studied the use of balloon pump for AMI with or without cardiogenic shock, and balloon pump use in patients with cardiogenic shock reduces mortality. Patients with moderate hypotension showed no benefit. And this is an important study because it may help explain the findings of SHOCK 2, which had a patient population with moderate hypotension. This meta-analysis of 16 balloon pump trials included a larger number of patients and was able to discern a benefit in AMI patients with cardiogenic shock. The analysis supported use of balloon pump in sicker patient populations and hypothesized that this group may experience greater benefits. So this supports findings by Schroeder and Chung, who found that patients with the worst LV function had the most improvement from balloon pump therapy. And the information is relative to SHOCK 2, again, because the hemodynamic profile presented in the study seemed to indicate that this population was not as severe as expected. Both systolic blood pressure and overall mortality rates were higher or lower than expected from the cardiogenic shock population. It is possible that the study demonstrated that patients with less compromised hemodynamics may not have the same benefit as those with significant hemodynamic impairment, as Baker was able to deduce from his meta-analysis. So now I want to move into, after kind of reviewing some recent clinical studies, I want to move into a little bit different treatment method and thought process. So as heart failure rates continue to rise and patients are managed longer with the disease, the likelihood of acute events on top of chronic heart failure are likely to occur. Current practice has recognized the need for hemodynamically guided treatment in heart failure using monitoring tools such as thermodilution and relative parameters. And as a result, we have determined that the wave calculation of flow on the Arrow systems, which is currently used for intrabeat timing, can be calibrated to provide a measure of the beat-to-beat stroke volume and therefore cardiac output. This type of algorithm would provide clinicians with immediate hemodynamic monitoring from the start of balloon pump therapy to determine if the patient is a responder or requires escalation of therapy. This section now will discuss the basic concept of the flow calibration method for volume and share the initial test results with you from patient data stored from the original WAVE study. Now, the purpose in the development of this program is to calibrate the wave flow calculation for accurate volume. Currently, again, the flow calculated by WAVE is used only in the time domain. It does not provide accurate volume information. Now, this project was designed to develop and test a method to calibrate the flow wave for volume. And once the calibration method was developed, it was tested using, again, actual patient data from the original WAVE study under a variety of clinical conditions. Now, currently, there are two accepted methods for calculating cardiac output. We have thermodilution, which in this method, uses the washout principle to determine the stroke volume. And the second method, pulse contour analysis, uses an analysis of the arterial pressure waveform, and it calculates the area under the curve during systole, which is a measure of stroke volume. Now, traditional pulse contour methods have been shown to be inaccurate during balloon pump use in prior studies, so thermodilution is generally required for this measurement in patients on balloon pumps. Hence, we had to figure out a way, though, to make sure we are only looking at stroke volume coming out of the ventricle and not factoring in the additional augmentation curve. So monitoring of cardiac output we know is important in determining if the patient is responding to balloon pump therapy or if they require escalation of therapy to a more powerful MCS device. And studies by Ramanathan and Sintek have shown that hemodynamic response of blood pressure and cardiac output in the first 30 minutes to 2 hours predicts if your patient is going to be a responder to balloon pump therapy. Therefore, having the ability to monitor cardiac output from the start of pumping may be an important treatment aspect. I haven't had enough coffee yet. So when we look here, the Windkessel model shows how stroke volume ejected from the left ventricle into the aorta becomes pressure wave. Now, in the wave calculation, we use the 3-element model, compliance, impedance, and resistance, as the measured and predicted AP waves are very similar. In this diagram here, some of you may have seen it in other presentations I've given. This shows the AP measured from the fiber optic sensor on our catheters in red, and the calculated flow wave for the wave algorithm in yellow. The flow is the volume component of pressure, and by calibrating the flow wave, we can measure stroke volume and then cardiac output. This diagram here, it gets a little bit strained on the eyes, but the diagram shows the method used for calibration of the flow wave. And under normal non-assisted beats, that top left graph there, under normal non-assisted beats, the beginning and end of systole are determined, and the red mark on that waveform show you those points. And on the flow wave right below, at the point of the aortic valve closure, the flow is brought back to zero, and this will be used during the assisted beats to predict the pressure and flow without augmentation. Now, on the augmented beats, that top right graph, at the point of aortic valve opening, the pressure is estimated to match the normal or unassisted beat, and on the flow wave, the calibration from the normal beat is imposed at the end of systole. So the beat is then simulated backwards and quote unquote fit to the normal beat at the end of diastole. And this is done several times to optimize the fit. And based on these curves, the pressure values and volumes can then be calculated. So this slide here shows the importance and performance of the stroke volume calculation during vena caval occlusion, which produces obviously a significant change in volume over a short time. And the main graph here in the top left shows the AP pressure waveform with the beginning in red and the end in blue of systole marked. The start and end of systole will mark the area for stroke volume calculation and is accurately performed here in the model. Now, the middle graph on the left, this shows us the measured LV volume from a conductance catheter. And then the third or bottom graph, this is important because it shows the stroke volume measured by the conductance catheter, those little plus signs, as compared to the calculated stroke volume by the model, so those are your little circles. The accuracy of the calculation and the ability to follow the change in stroke volume is demonstrated here. You can see that they stay very close and they correlate and follow each other. Now, the top right graph shows the individual patients measured versus calculated stroke volumes, and the correlation is high. And the graph on the bottom right shows the Bland-Altman curve as the calculated versus the measured stroke volume. And the accuracy range is plus or minus 5 cc's. Now, this demonstrates the agreement of calculation when compared to the measured stroke volume. Here we're going to see arrhythmia. Arrhythmia we know is common in our heart failure patient populations. We see it a lot, and actually just had that conversation a little bit. And this algorithm now is tested under moderate to severe arrhythmias. And you can see that the stroke volume is changing significantly beat to beat, but the calculated value follows the measured value very well. And the accuracy range is plus 8 to minus 5 cc's. So it's a very tight correlation there. And multiple patients are shown, and the calculated stroke volume is well correlated to the measured stroke volume using this method in that patient population. Now, this slide shows the same information as the prior slides, but now we're going balloon pump off to on. And this is where we saw the biggest abrupt change in our volume. And this is when we can see here that, again, the algorithm calculates stroke volume accurately, but follows the changes in stroke volume. And the accuracy of the measurement during the abrupt change in volume when we initiated therapy, that change in volume was plus 11 to minus 10 mLs or cc's. And this is the widest range of measured to calculated stroke volume that we saw. But once the stroke volume change was stabilized, the accuracy improves back to plus or minus 5 mLs. So we conclude that the model for calculating stroke volume and cardiac output is feasible with our catheters and our wave calculations, and within the accepted accuracy range of thermodilution of plus minus 15%. Now, the algorithm faithfully follows the change in stroke volume, which may be more important than accuracy of the readings themselves. And this method will allow the monitoring of stroke volume and cardiac output, along with patient hemodynamic pressures using the balloon pump and the catheter without any other devices from the start of therapy. Now, this will provide a quantitative set of information for clinicians to determine if the patient is a responder to balloon pump therapy or if we require escalation of MCS therapies. Now, remember, balloon pumps are the first and highest used mechanical assist device due to the safety profile, the ease of use, availability. It's also cost-effective, low risk, and other devices, including Impella, do have higher levels of complications, cost, and no better outcomes than balloon pump as discussed. Now, given the continued number of publications and increasing global use of the device, the balloon pump is expected to remain the mainstay in first-line mechanical assist in the near future. SHOCK 2 adds more information to our understanding of balloon pumping, but alone is not sufficient enough to change practice. While it represents an important indication for balloon pumps, it is not the only indication for its use, And many experts agree that balloon pumps should remain the first line of defense when medical intervention fails to achieve the desired effect in high-risk patients. Now, remember, balloon pump is the beginning step in the escalator of MCS, and having the right tools to determine if your patient is a responder or not lets you know when to start moving up that chain. All right, thank you. Questions?